Okay, I'm gonna try to add a We got it.
Hi. Oh my God. Hi.
We
Good evening. I don't know what happened. It was it
okay.
just wouldn't let me add. But hello.
Perfect.
Sorry about
Hello.
that. It wasn't working on my end. I don't know what happened. But good evening. How are you doing?
Hello. I'm glad we could do this. Do you have an echo on your end? You hear everything okay?
Yeah, everything's
Okay.
perfect. Clear. No echo. Yeah.
And I just came from Kids Run Club, so
Oh, fun,
excuse my
fun.
appearance. But I'm really excited to talk about this topic.
Yes, for
I'm
sure.
sure you see it all the time come up in conversations.
Yes, so this is, and we know it's Autism Awareness Month, but I was thinking, do we want to start with a little introduction?
Love it. Yep.
I will introduce you, and then you can tell a little bit about you, and then I'll tell a little bit about me. So
Perfect.
thank you, Jean, for joining me on this little collaboration. I mean, this being Autism Awareness Month, I just wanted to kind of get some information out there. But Jean Horney, you are a speech therapist extraordinaire who has a special interest in feeding concerns with children. And so please go ahead and share exactly what you do.
Okay, so as you said, I am Jean Hawney. I am the owner of Little Eaters and Talkers. I am a feeding specialist, a certified lactation consultant, board certified swallowing specialist. I primarily see children in the home and in a clinic here in Houston, Texas.
Mhm.
I also do virtual visits with a lot of people and parent coaching. I see, the bulk of my caseload are babies and
Mhm.
toddlers, but I also do speech therapy and myofunctional
Yep.
therapy.
It's amazing. I think that's how I kind of got to meet you. And
Mm-hmm.
it has been wonderful getting to know you. So, yes, I love it. And I think I've sent quite a few families your way to
Yes.
Little Eaters and Talkers. And we actually are now neighbors, I hear, in the same building.
Yes,
Um,
we are. I know I haven't visited you. I need to visit
Yeah,
you.
yeah.
We are.
And I am Dr. Ida Khanum, a pediatrician. I have a small concierge pediatric practice, a boutique practice here in Bel Air in Houston. I've been a pediatrician for 10 years. And again, my practice is a boutique practice. The goal really is to provide very personalized care. Families love it because it's small, a couple of hundred patients, get very one on one care, same day appointments, being able to text, get care taken care of, very proactive approach of taking care of kiddos. And two other things that I do is I do autism evaluations and ADHD evaluations in my practice. And that is separate from being a member of my concierge practice. And so I think the big thing has been that it is April, and with my autism evaluations, I mean, often things come up, and I'm on a lot of social media platforms giving education, but a lot of the times questions come up with feeding and feeding concerns. So I thought this would be a great topic to bring up and talk with a feeding expert, or at least to get insight for families. I think information, I really like our families in the community to get validated information, from people who are validated sources. And hopefully this will help people in the community if they have a child who is on the spectrum, or a child that has a hard time with certain foods, sensory aversions, and things like that. There'll be techniques that we can kind of talk about that may potentially help these families. So that's why I thought let's get together and do this. So thank you so much for joining me. And I am very sorry that my Instagram for some reason was not working, but that's okay.
We got it.
That's okay. We
We
got it
got it.
working.
Yes.
So that's the thing. So what I was thinking, I thought, to kind of make it informal. I mean, again, we have the chat open, so if anybody has any specific questions, please go ahead and shoot it. But I had come up with some questions that over a period of time, families have asked, and I thought it would be a nice thing to present. And so, I'm gonna read out some of the questions, and then Jean's gonna come on and give her expertise, and then if I have something to add, I can add. And of course, if there are questions coming through, then we'll kind of try to answer those as well if we can. I think that's a good format,
I
right?
do. I
Yeah.
like that.
Okay, awesome, awesome. Okay, so one of the first questions that a week I sort of brought up were what are some of the common reasons for food aversions in children with on the autism spectrum?
Well, I mean, this is a great place to start because we see it. It's very common in the majority of children with autism. And, we see these extreme, sometimes it's extreme and they're pretty consistent, these avoidance refusing to eat foods based on texture or temperature, the color, even the brand. I mean, it's pretty wild what a child on the spectrum takes in from a sensory
Right.
level, and that's pretty much a lot of it comes down to sensory.
Mm-hmm.
And with sensory, we all know about our five common
Mm-hmm.
senses, our five senses, right? Vision, what we see, what we hear, what we taste, what we smell, what we touch. But there's even more senses than that,
Mm-hmm.
or that a lot of occupational therapists dive into.
Right.
But regarding to with our feeding and our kids on the spectrum, we have our sensory, and then a lot of what I see are the behaviors that are attributed, the routine and the structure, and what we do as parents to accommodate our children, whether
Right.
they're on the spectrum or not, right?
Mm-hmm.
A lot of our children kids like routine,
Yeah,
but then some kids like routine so much that it's so hard to break from it.
that's right.
And that
That's right.
becomes part of the struggle with feeding.
With the kids on the spectrum. And I'm coming
Mm-hmm.
from that, sometimes I go back to your terrible twos and the picky eaters. Those children, a lot of them are not on the spectrum, right? But they are
Right.
picky, and it comes back, I think, down to exactly what you were saying, the senses, but also some kids like routine, and some kids like routine more than others, and then they
Mm-hmm.
kind of grow out, or they kind of mold into a new pattern, or sort of adjust. And children on the spectrum sometimes have a harder time doing that. But I had a question, and this was something else that came up while you were just saying something. So when you have a child who has a food aversion, so for example, they have like a certain pattern, do they flip in and out of that? Like if someone has an aversion, so they like, for example, they don't like slimy food. Okay, and as this little child grows older, can they go in and out from not liking slimy food to liking it, if you change the presentation in a way, or once they've got that, it's kind of like stuck with it?
Oh,
What have you
but
seen?
that's the most beautiful thing about feeding therapy.
That's right.
Like that is why I love what I do, because we see the progress.
Hmm.
It takes practice, it takes patience, it takes other
Hmm.
caregivers really buying
Right.
into it. It takes a lot of meltdowns
Hmm.
and temper tantrums. But just like even what you said with our terrible twos phase,
Yeah.
you're going to have a couple of nights probably where your kid might go to bed a little hungry.
Hungry. Yeah.
And
Yep.
but we've got to break bad
Right.
habits, because
Right.
if they've gotten into the routine where they get their pouch every night, and then you decide, you know what, we're done with this, we're not doing that anymore, you're going to have to break that cycle, and that takes time to break
That's
for
right.
everybody. But absolutely no, feeding therapy, that's why we can work through this. And so when I'm doing my evaluation, I'm taking in all those sensory
Hmm.
components of what a child likes. So when you went into mashed potatoes, for example, like that's a very slimy
Yeah.
food, and that can be very overwhelming. So we have to talk about, like, okay, how important is this food to
Hmm.
you?
That's
But
right.
also, is it affecting all slimy foods?
Right.
Right? Are we now avoiding yogurt? Are we now avoiding mashed fruits? Are we, like, I kind of have to go through each one. And then that's where we can find where it's kind of difficult,
Right.
because so many foods include
The texture.
some kind of wet,
Yeah,
oh, the
the wet
texture. Mm-hmm.
texture. So, but do you often find, because this was a separate question, I actually had a patient, and I know this is digressing from the question, but it came up because there was a patient, they're all wet, but the child will eat some of the wets and not other wets. So it's basically you're going to do trial and error. And as you said, I think the goal is to see what does the child really need to make sure nutritionally we're getting what they need, and then maybe working through it. Is that what you
Right.
kind of?
Like don't make a goal for your kid to eat
Right.
broccoli if nobody eats broccoli in
Yeah.
the house. Like I'm not doing that.
Yeah.
Like that's not going to
There's
be
no
my
point.
priority.
Yeah.
No, because some parents will be like, I really would love for him to eat
Yeah.
Brussels sprouts. And I'm like, well, how often do you eat Brussels sprouts? And
Yeah.
it's like once a
Yeah.
year.
No.
And I'm like, no, we're not working
Yeah.
on that.
There's no
So
point.
I have to navigate parents, and it really make things functional when a parent says, like, we can't go out to a restaurant.
Right.
I'm like, okay, those are the foods we need to
Right.
work on. Going back to that sensory and routine, typically kids on the spectrum and picky eaters, there's a lot of crossover,
Yes.
love packaged foods.
Right.
They love things that come in, either frozen and jars and stuff because it's routine. They know what they're going to get.
It
They're
tastes the same
visual,
and feels the same every time.
right?
Right.
And so with that, a therapy approach might be there's two things: food chaining.
Mm-hmm.
So food chaining is when a parent says, well, they eat Cheez-Its. They
Mm-hmm.
will eat the Cheez-Its, but they don't eat a grilled cheese.
Right.
And so we'll
Yeah.
go through these little baby steps to get them. And it might take us 10 steps
Mm-hmm.
or it might take us 3. It
Mm-hmm.
depends on how restrictive the child is.
Right.
But I help come up with that plan with the parent. The other thing is texture grading, or so let's say, sweet potatoes is a food, a staple of the house, but it's wet and slimy. But the
Right.
kid might eat this random Cerebelli pouch with sweet potato
Oh,
in it.
okay. A specific one. Yeah.
Very much
Mm-hmm.
so. Like, how do we get from one to the other? They're both wet and slimy,
Right.
but
Right.
there are little nuances and differences. And to you, you might get it, but to many parents, they'll be like, they taste the same. They
Yeah.
feel the
No.
same. And I'm like, oh, no, 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 no.
Yeah.
They don't. They don't
They
taste
don't.
the same.
Yeah. And it's just the child, what they like. So how do you typically start? So for example, if we have a family that says, I have a child who's on the spectrum and we're having a really hard time with food. So do you typically start with, okay, what are your staple diet, or what is the child really eating? And then what they're not eating, and then what food do you have in the house? And then how do we incorporate it? Is that kind of how you kind of do it to kind of make it more practical for families? Because
So,
definitely I
yes.
do recommend meeting with a food specialist and, someone
Mm-hmm.
like you for sure. But, even just to start off with, if parents have a thought, they're like, well, my kid just eats pizza slices, like chunks of little pizza,
Right.
and that's it. And that's their diet complete. And then, parents are scared to give them anything else because the child will have a tantrum, and then they're scared they won't eat, and it just goes out of control. And so, what would you recommend?
So in those cases, yes, I need to know exactly what the child is
Right.
eating. I might ask for a diet
Mm-hmm.
log. I might ask for routines. Like, I need to know times. Because a parent might go, all they eat is pizza, and then little do we know they drank an 8-ounce
Yeah.
cup of milk
Yeah.
from a baby bottle.
Right. Yep.
From a baby
Yep.
bottle.
Yep.
Like,
Yep.
I'm not kidding, and that's okay.
Yep.
I'm not one to judge
Yep.
because I know desperate times call for desperate
Desperate need.
measures,
Yeah.
and we need to get these babies fed, but then we are impacting their hunger cycles.
100%.
And, something I do find with kids with autism is the way they process hunger is very different
Mm-hmm.
than other
Mm-hmm.
children. And they have to
Yep.
be very, very motivated to eat.
Mm-hmm. Yep.
So, they like, I'm hungry, I'm motivated to eat.
Right.
Not a lot of kids on the spectrum don't get that motivation the same way as neurotypical. And so I have to also figure out what it motivates them,
Mm-hmm.
because then my approach might be a little bit more of a
Different.
behavioral
Right.
approach.
Is it
Uh,
presentation, color, things like that?
or even,
Activity.
oh, wow, okay, an activity. Yeah, that's usually what
Mm-hmm.
motivates kiddos
Yeah.
more,
Mm-hmm.
is the activity and figuring out that the positive reinforcement,
Of
how that works.
how that
And
works.
if a
Mm-hmm.
child is already diagnosed with autism and let's say they're getting ABA
Yes.
therapy,
Mm-hmm.
then I will talk with that ABA
Mm-hmm.
therapist to figure out how we can work together.
Together. Yeah. Because again, as you mentioned, that the other part is consistency, right? Replicating it in order for the child to learn it, right? Because if they're just going to meet with you, how often do families, if they reach out to you and they work with you, how often are you working with the families typically?
It's typically once a
That's
week.
right.
In some cases, I'll do school visits
Right.
too, because if they're already in school, I might have a little bit of a better outcome without the pressure
Yeah.
of what's going on in the home,
House. That's right.
because that happens a lot
Yeah.
where a child has already grown to be very fearful of what is happening at home.
Yeah. It's the pressure and the stress, and it becomes very stressful for parents because in their mind they're like, my child's not eating, and then you've got a child with very limited diet, and then all of that. Versus at school, it's a different environment. No, I totally
Yeah.
get it. Because the reason I was just asking is because often when I have families, even when their children, whatever the concern may be, if they're going to any kind of therapist, that's one of the big things I always tell them. I said the therapist is teaching you what to do with the child at home all the time, so that you're kind of replicating things, so that way your child it's sort of reinforcing. Because traditionally, I mean, a 1 hour session in a week is not going to be as effective as something that's kind of repeated. Is that also something that you tend to
Well, and that
recommend?
is why
That's the goal.
if the child is in school
Yeah.
and they have an
Right.
ABA therapist that's consistent with them, I'm like, oh my God, this is like
The
what I
environment.
need.
Yes.
Or educating teachers
Hmm.
on what they need to do differently, because they sometimes give in very, very easily
Yeah.
too. And it's like, okay, you just want bread. I'm just going to give you bread because I don't want the temper
Temper
tantrum.
tantrum. Yeah.
And that is what it is. So, but the other part about therapy, and this even as a
Hmm.
doctor and as a parent, is that many kids will do something for me that they might not do for their
Yeah.
parents.
It's pretty amazing. That is very true.
And I'm like, I call like, I wish I was Miss Rachel
Hmm.
on many days.
Hmm.
I'm kind of like a mini Miss Rachel.
Yeah.
And parents are just like in shock because they're like, they just ate that for you. And I have been trying this food for 3 years.
Yeah.
And I'm
That
like,
is very true.
well,
Yeah.
and then, but that gives
Yeah.
encouragement
That they
to,
can do it. Yeah.
that they can do it, and that you just have to build a different relationship around food with
Food,
the
yes.
child.
That is very, very true. No, that makes sense. Now, another question I had for you is, have you noticed with children on the spectrum if the food aversions are sort of I know a lot of it is related to textures. Have you noticed that? Because a lot of my patients that I see, a lot of the times the parents are like, really, the slimy stuff they really don't like. It's like they want the crunch or the hard. A majority of the time, that's what I kind of hear. But does it vary, or any information on
Well,
that?
so sometimes I have my pouch addicts
Hmm. Yeah. Yeah.
and my jarred food
Yeah.
addicts. Uh,
Yeah. For the little
Sometimes
ones.
I wonder, no, but it continues
Yeah. No,
on.
no,
Like
yeah.
they're three and
Yeah. Yeah.
four
Yeah.
and
Yeah.
they're still only eating pouches. I find that with a lot of my picky eaters, like the middle is the hard part. What I mean by that is like the crunchy foods
Hmm.
are usually
Fine.
fine.
Hmm.
They get that input, the crunch.
Crunch.
And
Yes.
then for sometimes the purees are okay because they're used to the processed or the
Sort of.
jarred foods. They've
Yeah.
gotten used to it. Um, it's that middle ground. It's
Right.
like even like the
Pasta.
pasta
I was going
that's
to
cut
say.
up or meats are hard. But now
Yes.
we run into that pickle of like the longer we're not chewing foods appropriately, then we tend to avoid
Yeah.
them
And they spit it out.
and they can spit it out.
Yeah.
Yeah.
And that's a lot. That is true. I've had quite a few patients, kiddos that are in my practice, that has been the concern. They'll try the protein, but it's, and again, age dependent. Because
Right.
even for regular little children, because of the teeth, even a regular kid, I have a lot of regular kids, just other kids that are 2 year olds getting introduced to more chunky food, and their teeth are coming in and they're just like chomping and spitting it out. And it's not because it's a food aversion, but it's really just because it's taken them so much time to
Mm-hmm.
chew, even if you made the small pieces. So being able to determine, is it just the normal, developmental stuff, versus this is a child who's actually having an aversion to, kind of the texture, or, the stringiness of the meat, and trying to kind of be, well, I guess parents, and that's part, I guess, what another thing that you kind of work with parents is how to incorporate,
Mm-hmm.
these
How
foods
to
into their
modify
diet,
it.
modify it, so that
Yeah.
way it's something that's nutritious for them, that they need, but also at the same time, something that they'll take.
Well, and to build off of that, something they'll take. I think a lot of parents, including myself, we go from 0 to 10,
Yes.
and especially with my picky eaters and my kids on the with autism, I go, oh no 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 no, we're going to like maybe step
Yeah.
one or half a
Yeah.
step. So and it actually ties into a lot because I've done so much, you know, info on like introducing allergens, for example,
Right.
and it's kind of
Yep.
that approach of allergens. It's like, no, we're going to do 1/4
Mm-hmm.
teaspoon of like
Mm-hmm.
chicken. We're not giving like a
Half a
huge
teaspoon.
portion of chicken, you know?
That's right.
And we're going to slowly try to, because I want success. I
Right.
want parents to feel successful and I want the child to feel
Right.
successful. Because the more often than not, I get texts from parents that say, it didn't work. And I'll be like, okay, why didn't it work? And then we realize we took too big of a step.
Right.
Or,
And I think so and you're very sorry, I did not mean to interrupt
no,
because
please.
I that's taking going on from that, that is another thing. It's like those small wins are positive reinforcement. So if you make a small portion and you're able to do that, that is a big win. But if that portion is so large, even the small amount that you took, you're going to look at it as a failure because you still have so
Mm-hmm.
much left on your plate. So, and that is exactly right. It's like how you approach it and sort of take it in small steps. I think that's the strategy that I think would potentially, with slow but steady is how
Yes.
you get to the end of the race, right?
Well,
Um,
and so with that, like if we have a goal
right.
food, and this goes to picky eating, a lot
Hmm.
of it crosses
Hmm.
over,
Yep.
is
Hmm.
exposure and
Yep.
consistency, being consistent and trying, you know, with toddlers and children, they want control.
Hmm.
And
Yep.
I want them to have some
Hmm.
control, but like at the end of the day, I'm the parent.
That's right. Yeah, that's right. You're very right. It's and it's also new. They want control, but it's how you make them feel that they're in control. I
Yes.
think that is being the parent. And so it's like often when I have patients with children and when they're with my picky eaters, when I'm talking to them, that's one of the things that exactly that's what I tell them. I'm like, they want to have control. So give them two healthy choices so they feel like they're in control, but you're happy with them taking either one of them.
Right.
So
Exactly.
it's a win-win for them and a win-win for you. It's not like you're replacing one thing with another. And another thing I just wanted to mention, a lot of kiddos, when we're having with food aversions or, limited meals, I often, just as you said, the milk, if people are replacing food with a calorie dense liquid, then you're killing the appetite and you're not going to get that food. So I often will tell parents to do any kind of hydration after the meal is done in the form of water so that you actually have a hungry child who's willing to make that effort. That's another one of the things that I just sort of bring in there sometimes when I'm talking to the parents as a strategy of trying to incorporate, especially in my kids that have sort of failure to thrive or not gaining weight appropriately. I think that's one of the things. Another question that I had is in what ways might cultural factors influence food preferences and aversions in children on the spectrum? Because we live
Cultural
in Houston,
factors. Yeah. In what way? Which
so
way?
we live in
Cultural factors
Houston.
in like, mm-hmm.
Yeah, food choice. So food choices, I think that's one thing, but also in the form of, what to try. So let me put it this way. I'm trying to be very politically
I
correct,
have a
like in,
feeling, but yes, I want to see
so
how you
so
phrase this.
so like because I'm half Swiss and half Pakistani, and in the Pakistani culture, a lot of the times, especially with babies, when the child is doing great for weight and height, but they are not looking like they don't have the little chunky folds. Often have families saying, "Oh my God, my child's not gaining weight or not appropriate weight," right? And so then the goal becomes like, okay, we're not eating enough. But as a pediatrician, when I'm explaining to them that no, you're doing fine, everything's fine, culturally there's like a little bit of a mismatch. So from that perspective, but that's one of the perspectives. But the bigger one that I was talking about was like, was related to foods and like if you tell somebody who doesn't eat pasta in their house that here I'm gonna kind of this is how you would do the pasta, like they have local cuisines that they like to
Right.
incorporate.
Mm-hmm.
I'm assuming it should be the same. It's basically you're just basically trying to tell them to be a little creative with how they're introducing the foods.
Okay, this is a great question because I do see a lot of Indian
Yeah,
families, Pakistani. I speak Spanish,
yeah.
so a few
Hispanic
Hispanic
families. Yep.
families,
Hmm.
and I laugh because you know I want the child to be eating the food. The goal is for the child to be eating the food that the family eats,
Eats.
right?
That's
So
right.
if lentils and rice, or I have
Yeah.
quite a few vegetarian families,
Yes.
right? So if lentils and rice is a staple of the house, then those have to be explored.
Right.
However, they're not forced.
Hmm.
We do not force those foods. And I think that's
Hmm.
where a little bit of the problem comes in.
Mm.
Because in many cultures, they're more
Yeah.
forceful and demanding.
Mm.
And that's where I have to really coach parents to back off. Another part, and I love this conversation because I find a lot of different cultures love to feed the babies,
Yes,
and
yes.
the babies are literally like,
Fighting.
get away from me. And the parents are like strapping their arms down and they're still shoveling it in. And, if grandma lives there, like it's just a lot of different factors in
Right.
education. Um, I have sometimes a really hard buy-in.
Mm, to helping to getting that done.
Yeah.
Yeah. So
And
I
I
think
do
that,
my best,
and
and
it can be a
it's a challenge.
challenge.
It is
So
a
what
challenge.
about when you have a child on the spectrum? So like today I had a call, and again I'm kind of relating it back. So today I had a call from a family that I did an evaluation on, and the concern is, he's 4 years old, 4.5 years old. He will um, try all the foods as long as somebody else is feeding him, but he will not do it himself unless
Hmm.
it's from the floor. So if there's food that falls on the floor, poor family.
I'm like, do we eat on the floor? Do we just
No,
eat on the floor?
no.
I'm
So it's
kidding.
actually it's it's and it was a real. The father was like, if I'll put it in a plate, he won't. It's like, it's, and there'll be some days where he will try. And he'll make a big mess, and I'm like, that's totally fine. But he's like, he will actually get nutrition in if mom is feeding him. And he'll open his mouth and he'll do it. He does have some textural stuff, but milder. But when it means open, holding the stuff himself and trying to put it in his mouth, he won't. But if he sees that same food that falls on the ground, like a piece of bread and things like that, he'll go right there, pick it up, and put it in his mouth. So it's like based on where. Oh, I can't hear you.
All right.
Oh, there. Yeah. No, I can't hear you. I think you muted.
Yes. Hear me?
Yes. Yes.
Okay.
Yes. Okay.
You and I both know that this is probably due to the routine.
Yes. Yeah.
Like this kid has adapted. So in those situations, I might say, okay, well, let's start with like your turn, my turn,
Mm-hmm. Mm-hmm.
right? Preloaded foods. I might look at the texture of the food. Sometimes food is very like very messy
Mm-hmm.
foods. I have a tactic that I called binders.
Mm-hmm.
And it's just like, is there an ingredient that we can add to this so that the food is more
Mm-hmm.
cohesive? So that if we
Grab
use our
it.
hands
You can put it.
or we use like a
Right.
meatball, right? It's more cohesive
Right.
versus ground beef falling all over the place. So that could be something to help. But also, does this child do this in school? And I actually have quite a few kids with autism and not that will only eat meals with the iPad on.
Mm-hmm.
And that is a slippery slope, very
Mm-hmm.
slippery slope. And it's a distraction, it's a habit, it's a routine. It's a parent saying, "Oh my God, you just ate that ginormous bowl of, rice and beans because the iPad was on." Little do they
You were
know that the
distracted.
meal took 45 minutes and the kid was distracted.
Mm.
So it's not really relatable to everyday
Yeah.
situations, unless
Right.
if you stay home all day and just let your kid do that. And again, no judgment, because if you have a child that's a failure to thrive or failure to gain weight, I'm going to help you come up with everything possible to get this
Gain the
kid to
weight.
eat.
That's
And
right.
if it means we have to use the iPad, but that we're eating a variety of foods,
For this period of time. That's right.
we'll build that
We're gonna do it.
confidence, and
Hmm.
then we'll try to fade the iPad or whatever it
Out.
is.
Right.
So
That's
that's
one of the things. The other thing I was going to tell you is because oftentimes with children who are on the spectrum, when they're little, they have the issues with the food aversion and wanting to eat themselves. But as they grow older, the concern switches to obesity.
uh-huh.
And, it flips the other way, because then it becomes like maybe when they were little, food was such a focus that now it becomes the focus. And then as they get older and they're able to go get things themselves, when they don't have anything else to do, or their form of, I don't know, self satisfaction or boredom, you can call it whatever you want, they go and they eat food. And then obesity, as they get older, and all the health concerns with that, becomes a concern as they get older. So how to come up with something that sort of is sort of in the middle,
Well,
where
do
we.
you see high obesity with kids who have autism?
Yes, very high,
I didn't know. Well, I
unfortunately.
normally see them 5 and under.
That's right. So as they older, and I will tell you, and the reason why I'm bringing it up, because I actually have a 15-year-old who's in my practice, who's been with my practice for a long time, and she is not. And I think she's like one of the few that is not. And the parents are both physicians. And I remember I brought it up to mom and I was like, how did you manage this? And she said, number one, she was diagnosed very early at 2. She started therapy. She said from the very beginning, we never made meal times our entertainment time. So she said she had some food aversions and we worked with it as long as she was getting a balanced diet with some protein and some fat and some carbs. And then, limiting all the extra calories. Snacking was also relatively healthy. They were able to create a diet plan which was sort of balanced and healthy, but it wasn't, their life did not revolve around being entertained by food, which I think we live in Houston. I mean, food becomes like everything. All the joys and happiness is around food over here, all your everything. But she said as a family, they didn't do that. And so she has never learned that when she's bored or she has nothing to do, she's not looking for food. You see what I mean? As a
But
15-year
that's
old.
like that sounds also like a family dynamic
Right. So they had
because
to do that. They trained her. So it was basically the family because she's an endocrinologist
yeah,
and she had seen the worst end of it all. So she was like, oh God, no, I do not, because that's even harder to do. Right. So she was like, let's prevent a problem. But the reason I'm bringing it up, because again, we have the children when they're little. And then if we're, so the goal, I think, the way I look at it is to kind of help the children create a diet, an ability to eat foods that are in good balance without making, because usually majority of the kiddos who are on the spectrum are not fated to thrive. You see what I mean? They will like some things, but they may not be a good nutritious balance. And so
hmm
that's what's going to come to my next question to you is, so, when you have a child who's on the spectrum and is sort of limited with what they're eating, and we're working through all these strategies, would they benefit from supplements, vitamins and things like that? Because I know the goal is to kind of get them to have it from their nutrition. But is that something that you talk to families about much, or?
you know, I tend to focus on. I have a background in nutrition,
That's right.
so I will talk about healthy proteins and fats and carbs and things like that. I find that kids on the spectrum and picky eaters in general are more carb
Yes.
focused and
Heavy.
empty
Yes.
carb
Mm-hmm.
focused. Now, I read a lot about how dietitians will say, you know, a toddler or whatever age doesn't need a lot of protein
Mm-hmm.
in their diet.
Mm-hmm.
However, I find that obese people and picky eaters don't like protein.
Protein. Yeah.
They don't prioritize it.
Yep.
And so with my in my feeding therapy, I do try to prioritize protein.
Yes.
Even with my kids with autism who are vegetarians.
Mm. So you do
And
tofu,
we'll uh tofu, or
lentils.
we'll even do black bean
That's
brownies,
right.
right? Or a
Oh,
protein powder that
nice.
fits the
Black.
diet. Like, oh yeah, there's so many delicious things because you might be that the kid might also have like a sweet
Yeah.
tooth. So we kind of have to work through that. Oh yeah, there's some really great recipes. Chickpeas is another one
Yeah. That's right.
that we can make some recipes with that as well. So I talk about the foundations of nutrition. If we have to go into more depth, I'll recommend a dietitian
Yeah.
normally.
Mm.
With the supplements, what's hard about that is because I have good eaters,
Mm-hmm.
so they don't really
At
need
the end.
supplements. So
Yeah.
I haven't
With
had to go
assist.
down that road,
Yeah.
but if a parent asks me, I'll tell them to talk to their pediatrician
Pediatrician. Yeah.
about that or
So
do
yeah,
blood work.
that's right. So you're very right, because the reason this question does come up, and as a pediatrician, I mean, that is something that I do see. So if I have a child that's actually getting, oral therapy, food, feeding, alimentation therapy, or working with a nutritionist, it's different. But there are a lot of families that, they're like, well, they have some food aversions, but then they're kind of working around it and stuff like that. And a lot of the times they'll be like, they're still not having a good balanced diet. So just in general, normally I'm not a recommender for multivitamins, but oftentimes with children who are on the spectrum, I may say you can do a multivitamin. And again, I tell the parents, I said, look, vitamins are only absorbed if there is a deficiency in you. Otherwise, it's
Mm-hmm.
just expensive urine. You are eating it and peeing it out. So again, if the child is growing well, getting a good balance, they don't typically need it. But that is one of the things that often comes up, because if you have a child that's really just carb heavy, heavy. That's exactly what you said. I mean, sometimes as much as sometimes people will try to work on it, and these are some really cool. And where can people get these ideas of your recipes and stuff? Are they on your website
I have
or?
some on my website, and then
Awesome.
some like parents send to me
Yeah.
also.
When something
So
works, it's
they're,
pretty cool.
oh my, all the time. I have a few parents that'll be like, "Oh my God, this worked!" And then also, I love to
Oh,
cook,
oh,
so
nice.
I
Good.
send a lot of recipes to parents as
Okay.
well
So you
because I'm like, well,
creators.
this works for my kid. I don't
Yeah.
know if it will work for yours, but the texture is like
Spot
perfect.
on. Yeah. So that
And
they'll work.
so,
Yeah. No, that's amazing. I think that is exactly it. Being a little creative and sort of thinking outside the box, I think sometimes, and it's amazing to have that relationship with the patients, with your patients. And so definitely, families can go to Little Eaters and Talkers on the website and sort of check
yeah,
out and see and follow you on Instagram as well for a lot of your information. What else?
I think my one
Some
comment for
questions. Yeah.
you as a pediatrician that I
Yes.
have a hard time with is that, if the median age of the child that you're seeing for an autism evaluation is what, 5 or 6, maybe? Is it?
Yeah, it should be 2 to 3, but on average, they're coming at 4.5 to 5.
Yes. And so my problem that I find that I wish more people would be more aware of is like there are red flags,
Yes.
and those red flags
Ye-
start early. And if
Yes.
your gut as a mom or a dad or a nanny or a teacher or whatever is telling
Yep.
you that this child needs to be evaluated, and maybe they don't have to be evaluated for autism yet because they're only 18 months,
Mm-hmm.
but that you're noticing these like really big red flags of picky
Mm-hmm.
eating, that it's important to get the early intervention.
That's right. And I'm so glad you brought that up because that has really been our biggest we're really trying to advocate to the community about multiple things. Number one, exactly the red flags. A lot of parents will think speech delay is the red flag. So whenever a child, and that's usually one of the big things that people will be, my child's not speaking or they're regressing. And so then they're starting to get worried. Or eye contact, right? If a baby's not
Mm-hmm.
making eye contact or not reciprocally responding, like, social smiling, those are big time red flags. And again, as long as you're going to your pediatrician for your appointments, definitely you want to bring that up. But yes, food, picky eating, food aversions, extreme reactions. I mean, these are, all children have some form of picky eating at some point, but it's not to the point where it becomes like your meal times become like
Yeah,
an
awful.
hour. Yeah, it's like a nightmare. It's like you start getting anxiety just thinking of trying to feed your child. That's not a normal, just not within the normal range of what the child at that age should be doing. And definitely, I mean, we tell parents all the time, if you're worried about it, bring it up to your pediatrician. You're worried about it, go get that evaluation done. And that's one of the things that we do at my practice. Our goal is to kind of get them in really quickly. So we don't typically have a wait list, and we can get them in within a couple of weeks. Again, the goal when it comes to a diagnosis is really actually to try and get them into therapy quickly, because early interventions, we all know, anything that you start, your brain's developing so rapidly in those first few years of life that if you're able to intervene, the hope is that you make things easier for the child to transition
Mm-hmm.
and thrive as they grow. So the longer you wait to start that, it's like learning a bad behavior, then you have to unlearn it, which is always harder. Versus when it's
Yeah.
starting, then you kind of say, no, 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 let's work with this. Let's kind of do this a little differently. They're more easier to change their way of doing things. But until otherwise, you've got this rigidity that comes in, and it's much, much harder. And then the end results are much not as not as wonderful as it would have been if the interventions were sooner.
Well, and even like before, like if a parent is scared to get a diagnosis, and
Hmm.
that's okay, I get that, right? Or
Hmm.
maybe the baby is still too young and we want to
Hmm.
see how they do. And a lot of times what I'll say to parents, if I do this first speech eval and I'm noticing the red flags, I'll say, well, listen, let's do 3 to 6 months of therapy
Hmm.
and let's see how we
Hmm.
progress, and we'll take it from there. We don't have to rush for a diagnosis in many
Hmm.
cases because they're still developing. We're getting them the
Right.
therapy they need,
Hmm. That's
unless
right.
if there's an insurance problem,
Yeah.
right?
and that
That's
and
when it comes in handy.
and we know that is our, so that's really why the
I know.
evaluations are required, is for insurance to cover the expensive therapies. I mean, literally, that is it. I have a patient right now who's 5 and he's never had any therapy because he didn't have a diagnosis. And so it's, but so again, I think you're very, very right. I think as long as, it's something's been picked up and we've already started the process. So when families reach out to me, actually, to be honest, I start my evaluations after the age of 2. So I said they need to have been 2. They should
Mhm.
have already failed the autism screening. Hopefully they've already got a hearing evaluation, they've already got a speech evaluation, they're getting speech therapy, and they already got things started. And then we've got like, yeah, we're really
Yes,
concerned. And
data.
then,
You have
right,
data.
exactly.
Hmm.
And then now we're going in and investing in this evaluation. So that way, if we have, and at my office, it's a very comprehensive evaluation. We kind of really look into lifestyle. And the hope at the end of the day is to come up with a full roadmap for these families to take on, with resources to use, to help their child thrive. And there's different things, and there's new data coming out. And I'm going to actually be making a video on one of them, but just sort of working. There's different aspects of a child who's on the spectrum that can be worked on, to basically help them thrive, because these children want to be able to communicate. They can't help it. It's like there's certain things that they cannot help, and we're basically coming in to try and make it easier for the child and for the family. And yeah, I mean, I get it. I get it that it's nobody wants to hear that their child is not perfect.
Right.
But then I say, none of us are perfect, and we're all different in different ways. But when you're on the spectrum, as we say, it is a spectrum, and you have children that get picked up earlier, and there are children that get picked up later, and it's based on certain behaviors, and either it's communication, speech, social interactions, behaviors of certain kinds that are outside the ability for them to cope and
Hmm.
transition. So, the goal is really we want them to be able to go to school, to be able to thrive in communities, and, be individuals. And the way to do that is to try and help them earlier on. So yeah, that is what I would recommend.
Yeah.
But any other questions? I did not see any questions. I think that was the end of my questions. We talked about social life, and anything else that you can think of? I try to relate it to some of our patients and the questions that I've got from my families over the
Yeah.
years.
No, I appreciate that. And then, when families come to see me, I provide them with a lot of
That's right.
resources. Again, we go to the parent coaching, we go through which approach would be more appropriate for their child.
Individualized,
And you
right?
you don't need, I mean, I'm out of network, so you don't
Hmm.
need a doctor's prescription to
Yeah,
see me.
that's right.
But the earlier we tackle it, the
That's right.
better. And then I also have occupational therapists that work with me.
Hmm.
And if I feel like this is like I need more support from the sensory perspective, I will absolutely have an occupational therapist jump in and provide more assistance.
Yeah. No, I think that's amazing. And that's exactly the goal, right? We all want to work together as a team, because to help, and that's another part of it. I think working together as a team with the family, with the
Hmm.
therapists, with speech, occupational, if a child is older, in school, psychologist, pediatrician, everybody put together, whoever is involved in the care of the child, to kind of work together on a very individualized basis to help that child thrive. And you're very right, because even we're out of network, so ours is a direct pay based package that we do. But the goal really is, you don't need, if you're worried, you're concerned, it is always, I feel, better in the best interest of the child to be a little more proactive and
Yes,
get
yes,
answers. And I've always felt therapy will never hurt your child. There is no such thing as too much therapy, is what I would say, because again, whatever therapy they're going to get, it's like once a week, or once, or it's
right.
not much, but it's basically, and it's never going to harm anybody. If anything, if the child didn't need it and you gave them therapy, they kind of finessed.
Amazing.
Yes, and
Yes,
you learned something new, right? And so that's how I kind of look at it. It's not like a medication or a pill that you're having to take. It's actually just sort of modifications that we do to help your child learn to thrive. And
exactly.
yep, well, this was great, Jean.
Yes, I
Thank
hope it was
you. I hope
helpful.
it was
Thank
helpful.
you.
Nope, thank you so much. And I really appreciate it. On a Tuesday evening, we got together, and hopefully we'll get together again, and we'll come up with
I
some other
know.
topics. And I think we're going to put it out there for people if they have other questions. I didn't see any questions come through. So, but you know how to download it
I
and
do.
okay,
And then on my blog, I have feeding tips
perfect.
as on your
Yes.
Instagram, you provide
Hmm.
information. My Instagram, I have a podcast
Oh, that's great.
also on
Oh,
how speech pathologists can help children with autism.
oh,
And
nice.
I'm available for parent coaching and helping these parents, right?
Yep, that's right. Thank you so
Thank
much.
you.
This was
Have a great
awesome.
night.
All right,
Yes.
you take care. Have a good
Bye.
night.
Bye.
Bye.
You
Thank